So thank you for having me. First of all, to those of you who are wondering where this nice sun or weather came from, this is from Los Angeles. I am taking it back with me tonight, so I apologize for that. This is really a pleasure for me to be here to speak to this audience. I feel like this is the home of VT mechanisms, VT ablation. And that's something that I'm very passionate about. So it makes it all the more special to be here. So thank you for having me. Here are my disclosures and funding sources. Let's make sure I can advance here. All right, let's see. There we go. Perfect. And these are my colleagues at UCLA. We're sort of a large group of clinical physician scientists, basic scientists, EP group faculty, and they, I think really facilitates the ability to function as a physician scientist, having this large group of multidisciplinary folks. In addition to that, I'm lucky that a bunch of people tolerate me in my lab. So these are the members of my lab that do that and do all of the work that I'll be showing you today. So what I spend most of my time thinking about are the two things on the screen here. On the right is ventricular fibrillation, ventricular tachycardia, as mentioned, and on the left is the neural control system of the heart. And my lab uses a variety of approaches to study the interactions between these two systems, the cardiovascular system and the nervous system. And most of our work is actually focused on rodent models and human tissue work. But for this clinical audience, I wanted to, or more clinical audience, I should say, this is not a neuroscience meeting. I wanted to focus more on the clinical aspects of our work. So most of the work I'll be talking about is actually in the porcine model, the pig model, and also studies in our patients. This audience does not need this slide. Most times when I'm speaking to neuroscientists, I'm having to convince them that it's important to think about how the brain and the heart work together and really trying to emphasize the impact of the nervous system on sudden cardiac death. But I think for this group, what I'd like to do is frame the way, or at least how we think about applying neuromodulation to patients. And this particular patient actually is the reason why I do what I do today. This is a patient I took care of as a second-year fellow. I believe this was a 52-year-old man who had used drugs in the past, developed a cardiomyopathy from that, and had since cleaned up and was doing well. He had a low ejection fraction, and he went to a local emergency room with monomorphic VT, as shown here. He was shocked and transferred to us at UCLA. And what's shown on this slide is his hospital course over about the next month and a half or so, or a month and a week, I should say. We took him for VT ablation. That didn't work. So what you're looking at here is day on the x-axis and sort of VT severity on the right. So number of shocks or, number of episodes of external defibrillation. And you can see here that we applied VT ablation. We did that twice, more antiarrhythmics, more shocks, more VT ablation. And it really wasn't until we instituted autonomic modulation in the form of left and then right cardiac sympathetic generation. I'll explain what that is in a second, that the patient's arrhythmias were completely suppressed. In fact, the patient left the hospital against medical advice after this. It declined an ICD and actually still alive today. This happened back in 2010. And one of my colleagues still sees him in the outpatient, and he's like, see, I told you guys, I didn't need an ICD. So, of course, this is a remarkable case. We collected the first 6 patients that we applied this form of therapy and published this back in 2012. So this is what sympathetic denervation is. It's where a surgeon, typically done by thoracoscopic means, a surgeon places a couple ports, identifies the sympathetic chain, which is shown here. Let's see, you can see this here. That's a sympathetic chain, and that's also right here. And then the surgeon snips it out, send it to pathology to confirm there are neurons there. And that's the therapy. And, we've long recognized that the nervous system has exerts very powerful control over the heart. One of the earliest accounts of actually neural-mediated sudden death is from, sort of the 16th century, where this story is told of a wealthy French count who had gone out hunting on a very hot day and came back to his castle, and his servants brought him a cold bowl of water, and he dipped his hands in, he's like washing his hands. And all of a sudden, the account goes, his face turned white, his heart throbbed violently, his legs failed him, and he yelled, exclaimed, "I'm dying, Lord have mercy." And he had sudden death from this. And some of you may realize that what he essentially did was he activated his sympathetic nervous system via cold pressor test. This is actually one of the means that we sort of non-invasively look at sympathetic function. And he triggered the spinal afferent circuit here that caused a lot of sympathetic drive to his heart, and he had sudden death as a result. Now, fast forward few centuries to the work of this man, Tomas Ionescu, who is a Romanian surgeon, who actually reasoned that if the past centuries of data has suggested that the sympathetic nervous system is involved in cardiac function and arrhythmias and angina, perhaps I should intervene on that to treat arrhythmia. So he had a patient who was a sort of a mid-40s male, who I guess by those standards was somewhat older. And that patient had coronary ischemia, had VT, and he applied that surgery I showed you, bilateral sympathectomy, to this patient and cured his VT. And this is his report published in 1921. So sympathectomy has been around for now, obviously, a long time. And that it stopped being used because beta blockers came about. But hopefully what I'll be able to convince you is that there's a role for this form of neuromodulation and others in our patients with arrhythmias. So with that sort of long winding background, here's really just a brief sketch of what I'd like to talk about briefly about cardiac neural anatomy. I'll talk about the mechanisms of sympathetic remodeling, in chronic cardiac injury, and why neuromodulation has value. And then I'll talk about some of the approaches that are taken and maybe some new work that's coming out of the lab. One of the first points I'd like to emphasize is just how densely innervated the heart is. I think that we all know that the heart's innervated, but it's on a scale that I think is hard to fathom. So one of the things that we have at UCLA is we have a way of getting near normal and diseased human heart. So when a patient goes for transplant, we usually get a big chunk of their heart, or hearts that are near normal but are rejected for one reason or another. We sort of have a system to get those hearts to UCLA, and we can apply a variety of techniques. Tissue clearing is one, where we could take a piece of the heart from humans, animals, whatever, and render it optically clear to facilitate imaging. And we also do immunohistochemistry. And so what you're looking at here is a confocal image of just that piece of the human heart that was collected by my colleague, Peter Hanna. And all you're looking at here, these are just the nerves in this very small chunk of the heart, just to show you how densely innervated the heart is. In fact, when this video sort of zooms back in, you'll see these little swellings along the nerves. Each of those are contact points between the sympathetic nerves, which is what we're labeling here, and cardiomyocytes. So pretty much every single cardiomyocyte, as well as many of the other cell types in the heart, are influenced by the nervous system and neurotransmitters that are released from the heart. In addition to that, there are actually neurons that sit within the epicardial fat pads of the heart. Those are called, the ganglionated plexi. And here's one up close. This is collected by my colleague John Tompkins, just to show you there's essentially a little brain that's on the heart, just like the GI system has its own brain. The heart has a brain as well. And the system works as shown here on the left in the schematic. Essentially, there are several reflex loops that govern the function of the heart. So that means that on a beat-to-beat basis, information from the heart is taken to various levels of the nervous system. So there's this intrinsic cardiac nervous system that was that ball of neurons, the ganglia I showed you just now. Information is also taken from the heart to the stellate ganglion, to the dorsal root ganglion, to the brainstem, and feeds all the way up to the forebrain. You might have seen recent data very sort of demonstrating that the workings of the heart, for example, can be associated with behavioral issues or can influence behavior, can influence anxiety. This is why some patients take a beta blocker before giving a talk. I didn't do that today, but that's sort of the system. And so this is happening on a beat to beat basis. I think to sort of illustrate the scale, the action potential duration for cardiomyocyte is a couple hundred milliseconds. That of a neuron is about 5 to 10 milliseconds. So within a heartbeat, you could have information, say there's a PVC, for example, on a previous beat. The nervous system will sense that, and that triggers an entire reflex that gets instituted before the very next heartbeat occurs. And we know this because we can actually record from various parts of the nervous system and relate that to blood pressure and the ECG. So here, for example, we're recording from the stellate ganglion, which is this area right here. And what you can see, each of these spikes, these are 2 different channels, and each spike represents an extracellular action potential from a neuron. And we're relating that to cardiac function. So you obviously recognize that this is the LV pressure tracing here. This is ECG tracing. And you can see how for each heartbeat, there are neurons that have specific firing patterns to track what the heart is doing on a beat-to-beat basis. And what's interesting is that this is it's integrated. The cardiopulmonary function is integrated as far as the nervous system is concerned. So you can see that these neurons stop firing when you take a deep breath. This is respiration here. And once you breathe out, they sort of pick back up again. So the entire system is tracked on a very, very close basis. So that's what happens in a normal heart. In the setting of cardiac injury, chronic MI, chronic heart failure, I'm summarizing decades and decades of data into this working model that I will sort of come back to over and over again. And the working model is that following an initial cardiac injury, there are a bunch of processes that are initiated that drive remodeling of the nervous system. And if there's one message to leave you with today, it's that injury to the heart trigger changes in the nervous system as well. So cardiac injury triggers neuroremodeling, and that neuroremodeling can be identified and harnessed to actually treat the heart. So as this model illustrates here, following cardiac injury, there are changes that there are sort of adaptive alterations that happen to the nervous system. I'm just using the stellate ganglion as an example here. That's driven by a number of processes, cardiac afferent activation, and I'll show you that in just a second. And that, sort of triggers a multicellular paradigm that essentially leads to sympathetic activation, which is what we recognize is why we give patients beta blockers in heart failure and after MI. And the same thing happens to the nervous system at the level of the heart. So that rich network of nerves that I showed you in that image, that also remodels in the setting of cardiac injury. And together, these 2 processes trigger sympathetic activation that then drives arrhythmias. And I'd like to show you some evidence for that. So starting in the stellate ganglion, the nervous system, this is sort of the model that most people have in mind when they think of cardiac innervation, is that there's some neuron somewhere that send axons to the heart that sort of drive cardiac function. But it's a lot more complex than that. This is some single-cell RNA-seq data that I'm not going to spend too much time on, but it's of the stellate ganglion. This is, again, where the neurons that provide sympathetic drive to the heart, that's where they live. And you can see here that it's really just a rich region with a variety of cells, of which neurons are actually a minority. Okay, so you have a lot of satellite glial cells, macrophages, Schwann cells, endofibroblasts, et cetera. And this essentially mirrors exactly what you see in the brain. So the same diversity of cell types in the brain that work together to sort of give us cognitive function also exists in these sympathetic ganglia. So one of the first things we did was to take the ganglia we were collecting from our patients with VT and cardiomyopathy and examine the tissue. And so just to sort of illustrate it here, this is, again, the neurons are sitting up here in the stellate ganglion and sending axons to the heart. So when the heart gets injured, they respond to that injury. And so in our patients, what we found is that when we control them to, say, organ donors about the same age, we found evidence of oxidative stress. This is extensive lipofuscin deposition. So we'd have a patient a young patient with chronic cardiomyopathy and VT, for example, whose neurons had accumulated so much lipofuscin that they look like someone twice his age, for example. This is a marker of aging. We also could identify activation of the supporting cells of neurons. These are satellite glial cells. The neurons start to switch their neurotransmitters. And importantly, we find evidence of chronic inflammation. We could find these inflammasomes within the ganglia. Again, the primary injury here is to the heart, but all of this is happening in the nervous system, and it's causing these maladaptive changes that essentially cause sympathoexcitation to the heart and can trigger arrhythmias and sudden cardiac death. And in fact, this isn't just something we see in patients. We could reproduce this in animal models. So one thing that we've spent a lot of time doing is actually recapitulating all of the findings that I showed you from our patients in our rodent models and also in our porcine models, and we're able to do that. One example I'll show you is of activation of satellite glial cells. So let me get to my mouse here. And these are, again, the supporting cells of the neurons. They essentially form a barrier that regulates the microenvironment of each neuron that controls cardiac function. And so just to look to see if we induced cardiac injury, could we drive glial remodeling or neuronal remodeling, just like we saw in our patients? So we did this in a pig model where we implanted pacing leads into the right ventricle, and we triggered BIDMC. So this is 50% PVCs. We have one lead for sensing and one lead for pacing. So it triggers this bigeminal pattern that you see here. And over time, the heart doesn't like that. As you know, this is essentially a model of PVC cardiomyopathy. You can see the ejection fraction plummet, LV dimension increase, as shown here. And here's what we find when we look at the glia and the neurons. So to orient you here, let's focus on the control. I can find my mouse. Neurons are here in green, and this thin rim here that's in sort of red and blue or purple, those are the glia. And you can see that in a control state, they just form just a nice simple rim around the neurons. But look what happens in the setting of the PVC cardiomyopathy. Look at how trophic these glia become. Again, the only thing wrong with this poor pig is that we've triggered a PVC cardiomyopathy in this animal, and the entire sort of glial architecture is remodeled. What happens in this setting, I won't get too much into it, is that it then sort of alters how glia regulate neuronal function and makes them dysfunctional. So just, again, another piece of evidence to support this idea of cardiac injury triggering profound neural injury. Now, and one thing that we've also done that in the interest of time I won't show today is now take those recordings that I showed earlier and actually put together what neuronal function looks like in the setting of cardiac injury. And I just list some manuscripts here that we've published on that. But essentially what it does is the ganglia works like a network. It essentially works like a brain. And so what cardiac injury does is that it triggers these sort of maladaptive signals within the nervous system such that it can't track how the heart works on a beat-to-beat basis like it used to. And so that is another form of sympathetic dysfunction that we need to address with, or that we can address with neuromodulation. Now you may ask, it's all well and good that the heart gets injured, the nervous system remodels to that. Is there a consequence to that? What is your evidence that these remodeled neurons are doing something different to the heart? And so to study this, we took an approach that actually started when I was a resident here in Boston. I sort of wanted to take advantage of the fact that, in the EP lab, when we're placing CRT leads in the coronary sinus, we have access to the coronary sinus. And the coronary sinus, as you obviously know, essentially can, give you a sense of what the milieu is of the myocardium, right? So you could sample neurotransmitters or catecholamines from circulation, but if you are interested in sort of what the cardiac milieu looks like, the coronary sinus is a better way to do that. So we started an IRB to actually collect blood from the coronary sinus in patients undergoing CRT. And we focused on this peptide here, neuropeptide Y. It potentiates the actions of norepinephrine. So if you liken norepinephrine to gasoline, neuropeptide Y is jet engine fuel. It really potently drives adrenergic tone to the heart. And we started by looking, going back to those patients that we took ganglia from, and we looked at the neuropeptide Y content in those patients, and we surprisingly found that it was actually reduced. You would think that there's sympathetic drive, you should be making more potent neurotransmitters, things that provide adrenergic drive to the heart. And we found the opposite on immunohistochemistry. You can see here that there's a reduction in the brown granules, which are neuropeptide Y granules. And this isn't an artifact of staining. And when we quantify that, we see that there's many more neurons in the stellate ganglion that have a low sort of neuropeptide Y content compared to in control, which is shown in blue here. And we looked at whether this was related to expression. Again, this is qPCR from human tissue showing that there's no difference in expression between controls and cardiomyopathy patients. So it's not that the neurons are making less neuropeptide Y. We looked at degradation. We didn't see that as well. And so we said, well, perhaps maybe it's being released. And so what I'm going to show you here is the coronary sinus content of this neuropeptide in patients, normal control patients. And you can see here, it's at about 5 picograms per ml. If you look at a patient with acute coronary syndrome or even a STEMI, that goes up. But look what happens in our chronic heart failure patients where that, sort of profound remodeling has occurred. There's a ton of neuropeptide Y being released into the heart. And if you look at outcomes of stable patients at the time of CRT implantation, okay, so you can distinguish any of the patients really. Those with very high neuropeptide Y levels above this number here were pretty much almost all dead by before 40 months, whereas those with lower levels were doing well. And again, I just want to emphasize, these are all patients that you can't really tell apart at the time of CRT implantation. So again, really, I think emphasizing the potent role of the nervous system. And I won't spend too much time on this, but we did some additional work trying to understand why neuropeptide Y was associated with this mortality. It led to arrhythmias and also pump failure. And what this data essentially shows is that when you look at ventricular fibrillation threshold in the setting of sympathetic activation, whether it's on the right or on the left, you can see that, with essentially just if you gave just beta blockers, you get this level of VF threshold. And then if you stimulated the sympathetics, right, you reduce that. But it's not until you give beta blockers and neuropeptide Y receptor blockers that you now are unable to reduce ventricular fibrillation threshold in the setting of right stellate ganglion stimulation. So again, the experiment here is that you give beta blocker and then you stimulate the sympathetic nervous system. And even with that, with high doses of beta blockers, you're not able to block the reduction of ventricular fibrillation threshold. But if you gave beta blockers and neuropeptide Y blockers in the setting of sympathetic stimulation, you are now able to prevent the lowering of VF threshold. So I would sort of maybe just summarize there again that cardiac injury triggers neuroremodeling. There's a consequence to that neuroremodeling. It actually impacts outcomes in patients. Now, what happens at the level of the heart itself? I showed you a rich, sort of dense network of sympathetic nerves in the heart. In the setting of cardiac injury, there's also profound remodeling that happens at the level of the heart as well. And to sort of take a primer, this audience does not need this primer at all, but you know that following cardiac injury, this border zone of that infarct looks just like this, where you have tissue that is scar. This is from a rat heart, shown here in this light color, and surviving cardiomyocytes are in this sort of brownish color. And you can see just how heterogeneous the border zone is. Everybody knows this. This is essentially the circuit for monomorphic VT. So monomorphic VT is just as shown here. There's a critical isthmus that the electrical activation meanders through, then it exits and re-enters, and this is monomorphic VT. You all know that. And of course, this is what we do, catheter ablation of VT4. This is the home of that, so I won't belabor that anymore. But interestingly, if you actually look at the scar, that same scar border zone that we put catheters in and we ablate to treat VT, it actually turns out that there is a profound a distribution of what we call nerve sprouts in that area. So these are sympathetic nerves that are trying to grow back into that scar border zone. And that's shown here as well. These sort of little brown spots, this is the edge of scar and surviving cardiomyocytes, again, shown here in higher magnification. And what's really interesting is that Peng Chen, now at Cedars down the street from us, actually did a study where he looked at patients who died in a hospital, and he could look at their ICDs, but also their telemetry. And at autopsy, they collected the hearts and actually looked at these sprouts in the scar border zone. And he actually found that those patients with cardiac arrhythmic death had the highest, and with scar in the heart, had the highest sort of number of these nerve sprouts, whereas those with non-cardiac death had much lower levels of it. So these sprouts that happen in the heart actually have, again, a significant impact on cardiac electrophysiology and the risk for arrhythmic death. And so we wanted to study if that was real, and we sort of recapitulated this in another animal model, and thankfully no one is eating right now. But this is a pig heart where we devised these, flexible, stretchable multi-electrode arrays to map cardiac electrical activity in real time in a beating heart. And so we created an infarct, and just like you saw previously, here's another scar border zone from our pigs, and you see here these nerve sprouts at the edge of scar and surviving cardiomyocytes. You see big nerve bundles, very small nerve twigs. And we said, okay, if we're mapping an area like this, what happens during sympathoexcitation? And so what we can generate from these maps, from these arrays, are electrical maps just like this. So what you're looking at is a 64 electrode array on a pig heart just like this. And looking at action potential duration, we're actually measuring something called activation recovery interval, which is a surrogate for action potential duration. And so this is what it looks like at baseline in one of these scar border zones. You can see that it's heterogeneous. What about when we stimulate the sympathetic nerves, the right or left stellate ganglion, and look how dramatically altered this becomes, right? So normally what would happen is that if this didn't have this heterogeneity, you would see sort of a nice smoothing out of action potential duration in the area. But what happens in the setting of chronic injury with these nerve twigs when you stimulate sympathetics is a dramatic increase in repolarization gradients. All right, those of us who are in EP know that this is essentially a harbinger of tissue that's about to get unidirectional block and lead to monomorphic VT, these steep repolarization gradients. And the impact of sympathetic nerves in the scar border zone isn't limited to repolarization. We see the same thing in activation. So here's, again, the same region here. You can see it has somewhat shorter APD compared to its surroundings and gets activated very late. So this is an activation map. Earlier activation is more blue, later activation is more red. And you can see here, this region gets activated very late in normal sinus rhythm. But during sympathetic stimulation, you can see again how it's dramatically altered activation in this border zone. This almost even looks like one of those VT isthmuses that I showed you. You can see how in real time, sympathetic activation can actually unmask essentially monomorphic VT circuits. So this is what's happening in our patients when they're running to catch a bus, patients with chronic infarcts. This is what the sympathetic nervous system does to their electrophysiology. So let me come back to this working model. I hope I've been able to show you some evidence for remodeling in the nervous system, remodeling at the level of the heart, and that triggers ventricular arrhythmias. Now back to our patient. Again, we applied sympathetic denervation for this patient. Essentially, the consequence of that is that all those changes that I showed you, the release of neuropeptide Y, the alterations to cardiac electrophysiology get dampened. Those changes get attenuated. And importantly, the sort of last major update for the ACC AHA-HRS guidelines for management of patients with ventricular arrhythmias actually now has autonomic modulation as a class 2B indication. And our hope is that as we understand neuromodulation better, we can sort of bring this up in the guidelines, because there's really a lot of potential for neuromodulation. So how is neuromodulation applied clinically these days? I've shown here sort of a variety of approaches, and the net goal of neuromodulation, just like you do with beta blockers and ACE inhibitors, is to decrease sympathetic tone, as shown on the right, or to increase parasympathetic tone. So there are a number of approaches by which that's done. Importantly, a recent study even suggests that transcranial magnetic stimulation, which is used for treatment of, I guess, treatment-resistant depression, can now be used to modulate VT. This is a study from Sam Nazarian at Penn, where they took patients with VT storm. I'll just skip through this, and actually put this magnetic coils around their head to institute neuromodulation. And you can see just how quickly the patients with the TMS, transcranial magnetic stimulation, have reduction in VT compared to those who are getting sham treatment. So this is real. At UCLA, we've actually done something crazy, like start a clinical service to actually apply this in patients. So our CCU can call a neurocardiology consult, and someone will come and think through what the best approach is for managing a patient's VT or arrhythmia. So I think this has legs. In the last 5 minutes or so, I wanted to maybe just talk about some other approaches that are coming down the pike in terms of neuromodulation. Maybe this is a bit of an overcall in terms of the future of neuromodulation, but I think this two approaches I think have legs. So this graph that I'm showing here is, or this plot is something that many of you would recognize that as the typical course of a patient who has initial major infarction. So patients doing fine, EF drops with the first initial injury for whatever reason. They may recover, but then over time they get sort of repeated heart failure hospitalizations, and then ultimately this leads to cardiac death. And the nervous system and neurohormonal remodeling has been implicated in this process. In particular, one specific neural circuit that might drive this is shown here. It's called the cardiac sympathetic afferent reflex circuit. And this circuit is what gets activated actually when someone has an MI. This is activated by angina. So the reason people can feel chest pain is because of the circuit and its projections to the brain. But it turns out that after the initial injury, this circuit stays active. So the job of the circuit is to alert the person to initial cardiac injury, and then it should turn off. It's like having an alarm clock that wakes you up. You usually turn it off and you get along with your day. But the analogy here is that this alarm clock doesn't shut off after waking you up. It keeps sounding over the rest of the day, which will of course drive you crazy. But essentially that's sort of what happens to promote this neurohormonal remodeling. It involves other aspects of the nervous system, certainly. And to probe this, if you look at, this is a canine study, but the same is true in patients. If you looked at a dog with chronic heart failure and you applied one of a number of compounds that can activate this reflex circuit, so that's the red nerves here, you get a bigger increase in blood pressure. Again, so the response of this circuit is once it's activated, it increases heart rate and blood pressure. And you see that in heart failure, this circuit is potentiated, the circuit is enhanced. And that's quantified here. And so our hypothesis is all of the drugs that we give for chronic infarct today do not address the inciting part of the circuit, right? So we give beta blockers, we give ACE inhibitors. Those drugs are meant to mitigate the adverse effects of neural remodeling rather than address the inciting cause. And this circuit here, so these nerves express high levels of a channel called the TRPV1 channel, right? This is this was cloned actually at UCSF. This is what Dave Julius won his Nobel Prize for a few years ago. And that channel is activated by a number of factors, including acidosis, et cetera. So it turns out that this channel on these afferent fibers drives this continued reflex processing, this continued activation. And it turns out that the most potent blocker of this channel is a compound called racinoferritoxin, which happens to grow where I grew up. right? It comes from this region right here. So I grew up in a tiny city of about 20 million people right there. And so it's like this thing followed me from Nigeria to the US. But for those of you who like spice, this is the Scoville rating. This is how spicy peppers are rated. You can see a jalapeno down about here. So racemic ferritoxin is like pepper, but it's so potent, its Scoville rating is 1 billion, right? So the top of the scale here is pure capsaicin, which is 15 million. This is 1 billion, so it'd be on the roof in terms of the scale. But it turns out that my people, use this for a variety of things, medicinal, for, as weapons, they use it for hunting, all sorts of things. But it turns out that at very low doses, you could actually ablate the fibers that contain these TRPV1 channels using this racemic ferritoxin. So Koji Yoshi, who's a postdoc from a couple of years ago, actually helped us develop the porcine model of this, where if you looked at, I'll just sort of get to the point here. So the marker of these afferent fibers is shown here. It's CGRP. And we could, with applying this racemic ferritoxin, we can selectively deplete just the afferent fibers and not sympathetic efferents or other types of neurons. So this is highly selective for this. And I'll skip through this really quickly. I'm sorry, I feel like I'm running low on time here. So what we can do is we can sort of apply RTX for short, so that in a normal MI pig, when we activate the reflex, you see a response here. And in the ones treated with RTX, that response is blunted. That's quantified down here. And so he took pigs, randomized them to this RTX 2 weeks after their initial infarct. And here's what he found was that he could make the infarct smaller. He could sort of reduce the adverse remodeling that happens a month after infarct. So here's a normal pig, here's one with MI, and you can see here that in blue, once we've applied RTX, we're able to essentially normalize most echocardiographic factors. He showed that this improved sort of structural remodeling in the scar border zone. I'm sorry, I'm going through this really quickly. And also reduces ventricular arrhythmias, whether that's by cesium chloride to look at sort of PVCs and non-sustained VT. Blue here, the RTX-treated pigs, and black here is the control infarcted pigs. He also did program stimulation and showed that he could reduce the arrhythmogenicity of these pigs. And the mechanism that he found was a number of things, but in particular, it reduced the electrical heterogeneity of the scar border zone. So this technology, believe it or not, has actually now been commercialized as a company that's looking to actually bring this to the bedside to randomize your high-risk patients post-infarct. So these are patients where they've gotten a stent, but maybe because of microvascular dysfunction or late infarcts, you're not able to intervene. These might be patients that, because they're not going to do well. There's tons of data that suggests that. So perhaps these patients, one way to treat them is with a compound like this. So more to come on that. The other I just want to talk about in a minute here, I'm sorry I'm running long, is vagal nerve stimulation. And this is where the game on or game over aspect of the talk comes in, is that most of you know that there have been a lot of failed vagal nerve stimulation trials. The reason for that is improper programming parameters of the vagal nerve stimulator. Vagal nerve stimulation is stimulation of the vagus nerve is already FDA approved for a variety of conditions, epilepsy, depression, migraine, et cetera. And we looked in a porcine model last year and actually found that we could reduce infarct size and post-infarct remodeling with vagal nerve stimulation in pigs. But there's a problem with vagal nerve stimulation, which is that the vagus nerve innervates a lot of different tissues. So if you propose to a patient that you would stimulate the vagus nerve, they might also have off-target effects to the gut, to the kidneys. No one wants to get a vagal nerve stimulator and not be able to control, their, sort of other bodily functions. So in recent work, we've tried to address this by taking an approach where we perform micro CT tracing of all of the vagus nerve fibers. We identify that there's actually a homunculus in the vagus nerve. So the fibers that go to different tissues are in different regions of the vagus nerve. Here's a reconstructed vagus nerve, for example, where we have fibers going to different regions. And so we recently designed an electrode, which is a circular electrode with 14 pairs of electrodes around it that allow us to selectively stimulate different parts of the vagus nerve. So this is EMG here to activate the recurrent laryngeal nerve. This is the portion of the vagus that stops respiration. And we could identify a portion of the vagus nerve that we can stimulate that only targets cardiac fibers. And so with that, the hope is that this makes vagus nerve stimulation a much more tractable approach for neuromodulation, because unlike targeting all of the fibers that go everywhere in the body, we can now selectively target cardiac fibers. So we're pretty excited about that. Let me just jump to my conclusion slide. I hope I've been able to convince you that cardiac innervation and cardiac function are very tightly linked, both in health and in disease, and that neuromodulation, I think, holds a lot of promise for novel cardiovascular therapies. And with that, let me thank my lab and take questions. Thank you so much for your attention.
This is really important work. One of the paradoxes is, obviously, not all VT is the same.
Right.
And most VT that we see doesn't occur under obvious sympathetic stimulation, whether we're talking about post-infarct VT or non-ischemic. And so it begs the question of what is that role in triggering, activating the substrate? And as far as clinical applicability, how can we stress the sympathetic, parasympathetic nervous system to potentially expose the vulnerability and identify specific patients in which sudden sympathetic stimulation may play a role in the trigger?
Right. That's a great question. And I certainly don't mean to suggest that the sympathetic nervous system is only capable of modulating the electrophysiologic substrate in the scar border zone, for example, in the setting of huge sudden sympathetic stimulation. Even low-level sympathetic sort of activation, it doesn't need to be this sort of huge surge, can actually trigger VTs. So there are a number of answers to your question. I'll just start with the trigger. So the sympathetic nervous system is actually able to modulate both the trigger and the substrate for VT. So in terms of the trigger, what happens in that scar border zone is that there is, and we've shown this with real-time catecholamine sampling in the heart, I didn't show any of that data today, is that it leads to a heterogeneous neurotransmitter release in the heart. So in the scar border zone, there are some regions with very large nerve bundles next to just a few cardiomyocytes, and those cardiomyocytes see way more catecholamine neurotransmitter levels compared to what they normally should see. So what that leads to is, again, excessive intracellular calcium, which leads to DADs, really EADs, DADs. So that's one way it affects the trigger. And in terms of the substrate, we know that what sympathetic, if you perform the study, and this has been done, where you actually remove, during the process of healing from an infarct, you remove sympathetic drive to the heart, or you make it even, the baseline heterogeneity in action potential duration, which we know is a harbinger of a arrhythmogenic substrate, is also reduced. So both the trigger and substrate are modulated by sympathetics. And again, you don't need a high level stim for it. And so the second part of your question, which relates to sort of applying this at the bedside to unmask, there are a couple of ways to do that. We published a study a few years ago where you could actually, the same way we do stellate ganglion block. So for our VT cases, we have anesthesiologists in the lab, and they can put a small electrode just next to the stellate ganglion. It takes about 10, 15 minutes to do that. And so we did this study because we wanted to demonstrate that indeed you can actually activate the system in a VT ablation procedure to unmask that substrate. Another approach might just be to give circulating catecholamines, for example. You could give a dopamine or norepinephrine, and what it'll do is that it will unmask the heterogeneity as well. So it turns out that where you get it. So what happens in the scar border zone is that you get heterogeneity. There's regions of denervation next to regions of hyperinnervation. The opposite happens in terms of beta receptor density. So when you give norepinephrine, for example, you will unmask that. So, so that can be done as well. Do we do that all the time in the EP lab? No. But in theory, I think that if you had a patient where you couldn't properly, induce VT or identify, or you don't see what could be a useful low voltage area to ablate, you could unmask that by these two approaches. Thank you.
For VT substrate-based ablation, how important do you think the radio frequency dispersion of those nerve spreads are for the effective ablation? And with the coming wave of pulse field ablation, the differential effects of electrification, myocardium versus
Nerves, yeah.
Do you think that's going to impact the results of our procedure? These lesions are going to be bigger, but if they don't affect the nerves,
very good question as well. So we've thought about sort of the first part of your question a lot, but I don't think there's a good way to sort of demonstrate that. I think it's somewhat obvious that because you're ablating and homogenizing the scar border zone tissue, you will be destroying this nerve heterogeneity as well. So I think we assume that, and if you have any ideas of how we could demonstrate that, I'd definitely love to hear. So in terms of PFA, I don't want to sort of make this seem like the only problem in the scar border zone are the nerves. The nerves certainly, I think, amplify the heterogeneity that promotes VT. So I think even if we're able to properly homogenize the substrate and remove the tissue that would respond to the sympathetic nerve heterogeneity, we probably will still have an effect. But there's some data starting to come out now in animal models, for example, from UCSF, looking at PFA for VT. And I think we'll still, I don't think sort of this concept here will reduce the efficacy of PFA for VT ablation. Peter, okay, thanks.
One place where we historically have used this fairly routinely, no longer, is on VT.
Right.
As a trigger base. I'm not sure if that's something that you guys use.
We do. We use it for lung effect. I have a fellow who's actually looking at genetic cardiomyopathies separate from lung QT, since it's established use for lung QT. What's different about the approach that we try to take is that for lung QT, a left sympathetic denervation alone is what's historically been studied. And what we find is that there's a resulting imbalance in sympathetic drive to the heart that may not be a good thing. So we started doing bilateral sympathectomies for our lung QT patients. It has caused, as you may have read in the literature, a lot of controversy. And so I think, I'm not sure that I'm recommending that bilateral versus left only, but we do use it a lot. And it actually, by the way, also, in addition to the trigger, modulates the substrate as well. When during left sympathetic drive to the heart, it sort of amplifies repolarization heterogeneity. And so the denervation would also reduce that.
That was a fantastic talk.
Yeah,
I noticed that many of your slides kind of stop at the neck or the thorax.
Yes.
And they didn't include mice. But so my question is there are all these cool optogenetic tools, where you can really understand things like the cortex, potentially. Now, a lot of me developed here, actually, from the endocrine.
Sure.
Do you think that they're useful for cardiology? There's not enough muscle mass to study. Just wondering, a lot of people are trying to encourage us to kind of get into that. You only have one fellow who's coming to the mouse is a model for study.
The answer is a resounding yes. In fact, that's most of what my lab does, is as optogenetics and chemogenetics and even fiber photometry. And I debated what I should show. And so I actually didn't show that work because I wanted to lean more clinically, but it is a very, very important area to study. I think that we are actually now dissecting all of these neural circuits in mice. And to your point about the brain, is that we actually have a study going on right now where we are driving a different neural circuit and actually looking at how it impacts the mouse's behavior to a number of behavioral tests. So what the heart does absolutely gets all the way up to the brain, and these approaches are actually quite powerful. Yeah, now I wish I should have shown something different, but.
Well, I have a related question,
Yes.
actually, based on Brad Lowell's work. We recently found that there are estrogen receptors in the dorsal motor neurons of the vagus nerve. And we have these women from the cardio-oncology side who are treated with hormone therapies who have these very pronounced vasomotor symptoms and also menopause, of course. So what's known about estrogen signaling there, and are there sex differences?
Yes, so we haven't looked at that. We looked at a slightly different area, and actually I'll send you the paper. We looked in the hypothalamus and actually found that there is a population of estrogen sensitive, estrogen receptor positive neurons that actually drive a programmed torpor, so like hibernation in mice. And an important part of that, of course, is heart rate reduction. So so that was sort of my contribution to the paper, was looking at the cardiovascular phenotype of these neurons. But absolutely, there are tons of sex differences in the nervous system that are yet to be uncovered. So yeah, be excited if you do that. Yeah. Okay.
Questions on the Zoom, so I think we can wrap up. Thank you.
Thank you so much. Sorry I ran long.